So let's move on to a beautiful topic, which is the bread and butter of all pediatric ophthalmologists, which is prescribing glasses in children. My first slide is of my son, which is to show that not only am I the doctor, but I'm also the parent here, a parent whose child has astigmatism and wears glasses. Therefore, the talking points of my talk will be, why do we need to prescribe glasses in children? How do we exactly examine children for refractive error, which was already covered by Dr. Renu? When do we prescribe glasses? How much do we correct? Do we undercorrect? And points to consider while choosing spectacles for children, because giving spectacles to children is not just a science, but it is the art as well. So this is where the art comes in, is how do you prescribe the spectacles? How do you counsel the parents? When do you change the prescription? How do you increase spectacle compliance in children? And how do we prevent bullying in children with glasses? So why do we need to prescribe? Of course, there's fear of amblyopia. There's a worsening of heterotropia or heterophoria, and children absorb information and learn both language and skills visually. And therefore, there's a fear of global delay, and that is language skills as well as other skills because of poor vision. How to examine a refractive error, we've already covered. So there's dynamic or dry refraction, which is also important in children. We tend to we definitely must do a cycloplegic refraction, and that is where the crux of prescription lies. And cycloplegia, either by atropine, homatropine, cyclopentolate, or tropicamide, whatever works for your type of practice. I prefer to give homide or homatropine instead of cyclopentolate, because a lot of my children are from they have fits and seizures, and I prefer to give homatropine. The other thing is serial refractions is what I would like to stress upon. That is serial refractions every 3 months under the age of 3, and serial refractions every 6 months from 3 to 6 years of age. And at each examination, check for amblyopia, check for refraction over the glasses. That is, the child is wearing the glasses and you refract over it with your retinoscope, and alignment for near and distance, wearing with glasses and without. So when do we prescribe glasses? Again, this is a lovely study by Liet S.J. et al. And here they've really asked some pertinent questions, which we all should ask ourselves, is that, is the refractive error within normal range for age? And which we already saw in our last study, presentation, that there is a huge range, especially in very young children. And these children are also unable to express their poor vision or blurred vision, or the fact that they can see better. So therefore, this normal range should be taken into account. Also, the fact that the visual system is a developing system in them. And so there's a chance of emmetropization at the young age, under 3 especially. Now, will the refractive error disrupt normal visual development, and also the difference between visual function, which is your normal Snellen chart or Lea symbols, and functional vision, which is how do they study, how do they move around, or what kind of activities can they do? And while prescribing, is there a heterophoria or a heterotropia? That is there a squint? And if they are aphakic or pseudophakic. Now, this is a chart which is mostly preferred by Indian ophthalmologists. This is the chart by American Association of Pediatric Ophthalmology. What I want to really stress upon is that this is preferred practice patterns, and these are guidelines. These are not set in stone, and it also depends on a lot of other points. So here we've seen, when would you prescribe myopes, when would you prescribe hypermetropes, and anisometropy and astigmatism. Those are your different columns, and your rows are according to age. And as you can see that when the age is low, you want to hold a higher threshold for prescription, meaning you will not prescribe each and every number. Your threshold is high. And as the age increases, your threshold of prescribing lowers. So how much do we correct? This is a very basic chart. Take-home messages if you're giving to an aphakic child, full refraction especially, plus near addition at infancy, and bifocals after the age of 1. Pseudophakics could be bifocals and progressive. I prefer progressive. In esotropes or esophoria, full cycloplegic correction. In exotropia, correct the myopia and undercorrect hypermetropia. And children are better able to tolerate anisometropia and anisokenia at this age. Of course, we saw this in the last session as well, that there was a lot of talk between binocular vision as well as anisometropia and anisokenia. But what is important a little over is also amblyopia. So I would go as far as to say 3 to 5 diopters difference is also well accepted by children, but the best is to keep it under 3 diopters of anisometropia. This is esotropia. You want to give full cycloplegic refraction, and if you're giving bifocals, prefer to give executive or flat top or D segment bifocals. In exotropia, if the child is hyperopic, then subtract about 1 to 1.5 diopters, and if it is a myope, give full cycloplegic refraction, which is still the lowest minus, and try to see if you need over minus if you're not going for surgery. Now, choosing spectacles for children, this is really important because your compliance to spectacles totally depends on this. You may write, you may do a brilliant refraction, you may give a very perfectly balanced evidence-based refractive error correction, but your child may not wear glasses if you don't give the right type of spectacles. And so here are a few points, that is, choose the correct frame size. The higher the number, choose smaller frames because there's lesser higher order aberration and the lenses are thinner. My last slide will be on spectacle compliance, and spectacle compliance depends on poor awareness, spectacle related compliance defects, psychosocial and financial barriers. And these are some of the solutions that are prescribed. And there's a beautiful study by Anuradha et al., which shows that these solutions actually work. Bullying and counseling. For counseling of children, ask about counseling at each and every session that you have with your child, that if they are being bullied, they may not open up to the parents, but they may open up to you as doctors, and counsel the parents at every session about guilt, shame, and blame on television and diet habits. And social education talks in schools as well as social media is important by doctors. Each doctor is an influencer. Thank you for your patient hearing.
Thank you so much, ma'am, for that very informative talk. I think the last 2 slides sort of suggest that how updated we have to be, not just as doctors, but also as parents and human beings. And we need to know all the new cartoons. We need to get them their attention.
Yes.
Them 3 or 4 months and keep checking their